Yeah.
Yes. Yes. Good evening, everybody. First of all, I thank the organizer of the IAPNEOCON, especially Dr. Rajesh, for inviting me to talk on nasal ventilation. I think in the last 3 days, during last 3 days, we have heard about physiology and lung mechanics in the first lecture. In the second lecture, we have learned CPAP, and yesterday we learned the mechanical ventilation, different knobs, and modes of ventilation, as well as some disease-specific condition. Today, what I am going to speak, this is the nasal ventilation. So what we have heard till last 3 days, first is CPAP, then invasive ventilation. As Dr. Murthy was rightly speaking, the CPAP is the standard of care. But what I am going to speak, what Dr. Sanjay was speaking yesterday, I will speak the same thing, which will mimic the mechanical ventilation, but without and without an endotracheal tube. So nasal ventilation means you are ventilating the baby with the same things what we are doing in invasive ventilation, but you will not use a endotracheal tube. So what will be my talk? I will talk what is NIPPV, non-invasive positive pressure ventilation. What are the different types of nasal ventilation? Some evidences and the practical applications and some of the things on NIV NAVA and also non-invasive high frequency oscillation ventilation. As we have already known that CPAP is a standard of care. For the last 15-20 years, it has become a standard of care. But it has been seen from various studies, and also you will also agree with me, CPAP and surfactant, many preterm babies will fail with respiratory failure. These are the different trials which have clearly shown that the CPAP failure rate around 50% as a primary mode. So before I start, let me tell you how many of you are using nasal CPAP and how many of are using mechanical ventilation and how many are doing nasal IPPV. Can you tell? Or you can write in the chat box. Here I cannot. So the CPAP failure rate can go up to 50% as a primary mode, and as a secondary mode also there may be failure rate of around 30%. That means although CPAP is standard of care, there may be some failure rate. So if there is some failure rate, what is the next option? So previously, as Dr. Rajesh was telling, initially what we used to do, we used to do mechanical ventilation once the baby fails on CPAP. But in the mechanical ventilation, there are some lot of problems. So what are those? So if you put a baby on tube, it has got its own problem. It has got both short-term as well as long-term outcome. What are the short-term outcome and long-term outcome? So this study has shown that to investigate the association between invasive mechanical ventilation and long-term neurodevelopment outcome in preterm infants. As it is, you have seen that the patient population was less than 30 weeks and requirement of mechanical ventilation for 2 days. Yet what they have seen, even every additional day of mechanical ventilation in preterm infants is strongly associated with increased risk of neurodevelopmental outcome at 24 months of conceptional age. That means every 1 day of using mechanical ventilation, it has got an adverse neurological outcome and long-term outcome. So what are the short-term outcome? As you have seen from this slide, there are two groups. One group extubation failure was there and one extubation success was there. In the extubation failure group, what we have seen, there is increased requirement of mechanical ventilation, increased requirement mechanical ventilation days or also non-invasive ventilation days. Supplemental oxygen requirement was also more and duration of NICU stay was also. That means if you go directly from CPAP to invasive mechanical ventilation, you have both short-term as well as long-term adverse neurological outcome. Professor Richard Pauline says that when you are intubating a baby, the investigator does know what he is going to do. And there are a lot of problems like there may be bolotrauma, barotrauma, rheotrauma. So all types of trauma can happen when you are using mechanical ventilation. So we need more effective and non-invasive respiratory support methods than CPAP. As we have seen, it is a non-invasive pressure control. Whatever waves, the The above, the first one, what we have seen, that is the pressure. You have seen that it is delivering pressure from minute to minute. Second one is the flow, and third one is volume. Same thing you will find when you are using mechanical ventilation with a tube. That means before going to invasive mechanical ventilation, we have got another option. So that is the bridge between CPAP and the invasive mechanical ventilation. That is the nasal ventilation. So how do you classify nasal ventilation? If you see from this slide, it nasal non-invasive ventilator support maybe constant airway pressure or maybe variable airway pressure. What I am going to speak today, that is variable airway pressure. It may be non-synchronous NIPPV or synchronous NIPPV or nasal high frequency or NIV NAVA or nasal BiPAP. So as I have told you that from CPAP to IMB, we have got a bridge, that is a NIPPV, nasal high frequency or nasal NIMB NAVA. So let me first talk about the nasal IPV, that is non-synchronous nasal IPV. So one important thing to remember, those who are listening to this lecture, whenever you are using non-invasive respiratory support or nasal ventilation, your baby's airways must be patent and baby should have good spontaneous breathing effort. Normally what happens when a baby spontaneously breathes, the diaphragm flattens, but the upper airway collapse is prevented by three simultaneous events, like opening of the glottis, stimulation of the pharyngeal pressure receptor by negative pressure, reflex activation of upper airway adductor muscle, stiffen and widen the pharynx because of genioglossus and genioid. As we have seen from this slide, when a baby takes a deep breath, the diaphragm flattens, the upper airway muscle gets stiffened, and the airway is patent. If the airway is patent and the glottis is open, then the inflation can go to the alveoli. So that means one important point, the learning point is that whatever mode of non-invasive respiratory support you are using, unless the patient has got good respiratory effort and glottis is open, then most of the breaths may not go to the breaths, may not be delivered to the alveoli. So what is nasal intermittent positive pressure ventilation? I think all of you know what is CPAP. CPAP is, what is CPAP? Can you tell what is CPAP? CPAP is a continuous positive airway pressure which is delivered both during inspiration as well as expiration, both throughout the respiratory cycle. As we have seen from the left-hand side, there is a continuous pressure, it is 6.9 pressure going on both during inspiration and expiration. And what is NIPPV? Here there is CPAP, but on the top of CPAP, you have seen some inflation pressure is there. That means along with CPAP, you are giving some intermittent positive pressure, which has got a PIP, PWP, TI, and TE. That means you are getting the advantage of CPAP as well as you are also getting some of the added advantage of intermittent positive pressure, which has got some PIP, PWP, TI, and TE. That means baby is getting CPAP and along with that getting some of inflation pressure. So that will increase the mean airway pressure. Yesterday we learned that if we increase the mean airway pressure, definitely it will improve the oxygenation. The second important thing is that and once you are giving intermittent positive pressure ventilation, that means you are recruiting some more alveoli, so it will increase the surface area and that will improve ventilation. That means NIPPV is nothing but it is CPAP. It is augmentation of CPAP by putting some intermittent positive pressure. Normally, what happens when you are giving intermittent positive pressure through a non-synchronous way, one of the important points that might happen that there may be a lot of leak. Because when you are putting a baby with a tube, definitely there will not be any leak. But when you are putting a baby with a nasal mask or nasal prong or nasal cannula, there will be a lot of leak. That leak to the interface or leak maybe to the mouth. So how to compensate for leak? Suppose you are using a machine which does not have a software for nasal intermittent positive pressure ventilation, then you have to regulate manually the flow. Normally, how do you know that your pressure, what you have said, that is actually appropriate or not, or flow is, or there is no leak? That means whatever pressure you have set, suppose you have set a pressure of 18 and ventilator is also delivering 18, that means leak is compensated. So if the leak is not compensated, that is why it is said that if you are using a machine which does not have a software for NIPPV, you can manually regulate the flow 8 to 10 liters. So by increasing the flow, you can adjust the PIP. So NIPPV can be administered in two ways. One is non-synchronized NIPPV and synchronized NIPPV. So if you use non-synchronized NIPPV, what might happen? As it is seen from the slide, the blue breaths are spontaneous breath, and these are all ventilator breaths. And you see that fast breath, when the baby is actually starting expiration, that time there is a breath. In the second breath, baby is in the expiratory phase and ventilator is giving inspiration. In the third breath, baby is in the expiratory phase, ventilator is initiated the breath. And the fourth breath, baby was inspirating, there was a breath from the ventilator. And finally, also you have seen the most of the breath are not synchronized. That means if you actually in non-invasive positive pressure ventilation or non-synchronous positive pressure ventilation, synchronization may occur by chance. That means what does mean synchrony? Baby will get the breath, ventilator also deliver the breath. And that can happen only 25 to 33% of the breath may synchronize by chance. So as I have told you earlier, if you want to actually deliver the inflation pressure towards the alveoli, first of all, the breath should be synchronized, that when the patient or baby is asking for a breath, ventilator will deliver the breath. And when the ventilator is delivered the breath, the glottis should be open. And if the glottis is only open, then only the inflation pressure can reach the alveoli. But if it is a non-synchronous positive pressure ventilation, that cannot happen. That may not happen even 70% of the case. Only 20 to 30% patient may be synchronized. Now you can ask me then what is the next option? Next option is the synchronized NIPPV. These are non-synchronous NIPPV, as I have already told you. Non-synchronous NIPPV, that means synchrony may occur by chance. Only thing you have to see, as glottis may not be open most of the time, so some of the air, if the glottis is open, will go to the stomach. So there will be a lot of abdominal distension. So one of the important point to remember when you are using non-synchronous in positive pressure ventilation, you have to always evacuate the stomach from time to time. Otherwise, there may be some gastric distension, and in the rare extreme cases, there may be perforation. But if you are very careful, that might not happen. So if the non-synchronous breath falls on the baby's respiration, then what might happen? As you have seen from the slide, this delivered pressure is synchronizing with the patient pressure respiration. So if this synchronizes with the patient's breath, the larger tidal volume can be recorded when the onset of NIPPV pressure peaks coincided with the spontaneous inspiration. That means when the baby is delivering, taking a breath, that time ventilator is also delivering a breath. So that will be synchronized. If this happens, then only there is only chance of 15% tidal volume will be increased. Second important thing is that if the baby is in apnea, that it is found that most of the inflation pressure may not go to the alveoli. And so that is why we have seen in non-synchronous NIPPV, if the baby is having throwing several apnea, that time it might not help, because only 5% increase in the tidal volume will occur and one or two breaths may be synchronized. So this we should be very careful. So what might happen if the ventilator breath is not actually synchronized with the patient breath? As we have seen from the slide, here this is the patient's expiration, and during times ventilator is pushing a breath. When the ventilator is pushing a breath and baby is in the phase of inspiration, so what might happen, because to get rid of this overinflation of the lung, there will be forced expiration by the patient, and there will be a delay of inspiration because of the Haring-Burra reflex. So what might happen when there is a Haring-Burra reflex? So the second mechanical breath occurred immediately after the end of spontaneous inspiration, activating a forced expiration and altering the patient respiratory rhythm. So that what might happen when these things happening? So there may be change in the respiratory rate, and also there may be change in the intermittent. There may be change cerebral blood flow and also blood pressure, and ultimately there may be some other deleterious effect. So if it is not synchronizing with the patient's breath, this might happen. So another important thing, as I was telling you earlier, when the baby ventilator is delivering the breath, then larynx should be open. If the larynx is not open, then most of the breath what you are giving, that will go to the stomach. So active laryngeal closure against intermittent positive pressure ventilation can limit lung ventilation in non-synchronous breath. So what might happen if there is a lot of non-synchrony? The same thing what happens in invasive mechanical ventilation, the same can happen in our non-invasive positive pressure ventilation. As you have seen, it is written, NIV is associated with high failure rates due in most of the cases to patient discomfort. Asynchrony during NIV-MB, important cause of discomfort and frequent reason for NIV failure. And synchronization may occur in NIV-NAVA, that we will discuss later on. So now the question remains how we can synchronizing the breath. Because for synchronizing a breath, you should remember ventilator delivering patient is initiating a breath, ventilator should recognize the breath. And once the ventilator recognizes the breath, ventilator should deliver the breath. So patient initiates the breath, ventilator recognizes the breath, and ventilator delivers the breath. This time is called the trigger delay. That means how ventilator can recognize a breath. So these are the four ways that patient can recognize the breath. One is by putting abdominal capsule, that is Gresby capsule, pressure trigger device, flow trigger device, NIV trigger device, NAVA trigger device. So what is Gresby capsule? Gresby capsule, it is a balloon filled with air and which is connected with the ventilator with a pressure transducer, and it is put just below the deepest sternum. So because of the abdominal movement or the movement of the diaphragm, it recognizes the breath. So the advantage is that it can detect the breath very early, but what are the disadvantages? Efficacy depends on its position, and if the capsule is placed too close to the rib margin, asynchrony may happen because of paradoxical breathing movements, or because of some, there may be a lot of artifacts because of tachypnea or because of some convulsion. Those can be detected as a breath. So Gresby capsule initially actually tried with infrastructure ventilation, but this ventilator is no longer marketed in US, so we do not find this trigger device. Second is a pressure device. Yesterday you learned there is a flow in the circuit. So during the flow of the circuit, if the patient initiates the breath, then there may be some drop in the pressure, and the drop in the pressure should be recognized by the machine. But the problem in the preterm infant is that preterm's inspiratory effort is very low. So if the inspiratory effort is very low, that drop on pressure may not be very so strong so that ventilator can recognize the breath. That's why it has got low sensitivity with frequent auto triggering or no triggering, or auto triggering may occur because of secretion or moisture, and pressure signal is affected by the leak. As I have told you earlier, whether you use mask or prong or nasal cannula, there will be leak. Once there is the leak, so that drop in pressure may not be recognized by the ventilator. So the best option is the flow trigger. Flow signal, there is a flow sensor. So there is a bias flow in the circuit. So when there is a bias flow in the circuit and patient initiates a breath, so suppose patient initiates a breath of 0.1 liter per minute. So once this 0.1 liter per minute initiated by the breath, so there will be change in the flow, and that flow will be detected by the machine. See here also same thing happens because there is lot of leak. So most of the machine, even with leaks, also it will be very difficult to the machine to detect the flow. So that is the disadvantage. That's why flow signal is affected by the leaks, and there is increased dead space because of the flow sensor, and there may be auto triggering because of secretions or moisture. So, but nowadays the differential pressure transducer remote tachograph that is connected to a software program that only detects a sudden change in the flow with respiratory effort, and it discards the slow change in flow signal of the leak. So that's why many machines, they claim that even there is leak, they will detect the flow which has got an inspiratory effort, and it will synchronize the patient's breath. Another is the NIV NAVA. Here the NAVA catheter is placed in the lower 1/3 of the esophagus, and it detects the diaphragmatic activity, diaphragmatic impulse. And it is more physiological, it is close to the actually patient's breath. That I will discuss later. So if there is synchronization, what might happen? So as I have told you earlier, ventilator is pushing glottis is open and ventilator is pushing a breath, so there will be inflation. So what we actually think that in non-synchronous NIPPV, actually inflation does not reach the alveoli, because if the glottis is closed most of the time and it is not synchronized, actually only 20 to 30% breath will be synchronized. The rest of the breath will be non-synchronized. Second important thing, it will increase the transpulmonary pressure. How it will increase the transpulmonary pressure? Because ventilator is pushing a breath and baby is getting a negative pressure. So ventilator is pushing and baby is pulling. So it will increase the transpulmonary pressure. Second is thoracoabdominal asynchrony is reduced. So I will discuss later on how thoracoabdominal asynchrony is reduced. So what happens that there may be improved ventilation, decreased work-out breathing, and increased comfort of the baby. Why thoracoabdominal asynchrony occurs in a preterm infant? Normally what happens in a healthy baby or in the healthy adult population, what happens during inspiration, there is contraction of the diaphragm. So abdomen goes up, and because of the strength of the inspiratory muscle and the strength of the diaphragm, the stiffness of the rib cage is maintained. So there is no collapse of the upper airway. But what happens in case of preterm baby? Because of the increased compliance of the chest, there is the inward pull of the rib cage, and there is outward push of the abdomen. So there is asynchrony. So if the baby's breath is not synchronized, then this asynchrony might happen. So here in the first picture, you see there is complete synchrony, and the second picture it is complete asynchrony. So the difference between the two waves that move in the same frequency, that is called the phase angle. It is seen that if the phase angle is 0, then it is synchronous. If the phase angle is 180 degree, then it is asynchronous. Here in the first picture, it is phase angle is 0, so that is complete synchrony, and second angle picture it is asynchronous with 180 degree. So there was a study that has shown that if you use nasal IMB, the phase angle is low. That means if you use nasal IMB, that thoracoabdominal asynchrony may be maintained. That is the importance of synchronous NIMB. So as we have already told that if you use nasal IPPV, you are getting all the advantage of CPAP. On the top of that, you are increasing the higher MAP, and also you are improving the lung compliance and reopen partially collapsed alveoli because of the positive pressure, and there will be greater tidal volume, decreased work of breathing, and reduced thoracoabdominal motion asynchrony, and decreased airflow resistance, and there is reduction in the apneic episode. So how it helps in central apnea? Once there is intermittent positive pressure, there is Hertz paradoxical reflex. I think all of us know what is Hertz paradoxical reflex. When there is a inflation in the upper airway, so it increases the inspiratory time. So it improves the inspiratory drive and reduces the central apnea. Similarly, high pharyngeal pressure activates the dilator muscle of the pharynx and reduces obstructive apnea. Similarly, high inspiratory flow, there is soft palate pushed against the heart tongue, oral cavity is sealed, and better breath delivery and reduced obstructive apnea. So what are the indications of NIPPV? Whatever indications was there in CPAP, the same indication we can use in NIPPV also. Here, as we have seen, as a primary support, it can be used in RDS, TTNB, MAS, or pneumonia. As a secondary support, you can use as a post-extubation as well as apnea of prematurity. What are the contraindications? Infants with unoperated diaphragmatic hernia, nasal obstruction, anomalies, tracheoesophageal fistula, immediate postoperative period for gastrointestinal surgery, etc. So I think we have already told that if we use nasal IPPV, the failure rate is less. As it is seen, NIPPV failure rate is around 5 to 25%, and already we know that CPAP failure rate is around 50%. That means all these 50% babies can be managed with NIPPV. Similarly, one of the important problem in our neonatology is bronchopulmonary dysplasia. We say that especially in the preterm infants, what we see actually in the preterm infants, even the best ventilator there is BPD. As it is seen, if we use NIPPV ensure that will decrease the incidence of BPD also. So this is a systematic review and meta-analysis of efficacy of non-invasive respiratory support for primary respiratory support in preterm infants with respiratory distress syndrome. Dr. Rajesh was asking whether we can use as a primary respiratory support. If you see the slide as a primary respiratory support, if you see it is always better than CPAP. It reduces the treatment failure by around 24%. Requirement of mechanical ventilation test may be reduced by 40%. Air leak also reduced by around 36%, and also reduction in the mortality by 40%. So that means NIPPV as a primary mode is better than CPAP. But the problem is that to provide NIPPV, you need a ventilator. And the cost of the ventilator, minimum cost may be 10 lakhs or 20 lakhs. So with the cost of one ventilator, you can buy many CPAP machines. Similarly, as a primary mode with RDS also, it has been shown there is no difference in the mortality, but the incidence of pneumothorax, rate of respiratory failure, need for mechanical ventilation, and CLD is also less in NIPPV. Second is that as a post-extubation, after post-extubation, what is the result? This systematic review has clearly shown that in the post-extubation also, there is advantage of nasal IMB over CPAP. Synchronous IMB has got an edge over non-synchronized IMB. The same thing has been shown. Respiratory failure will be reduced by around 25%. Endotracheal intubation will be reduced by around 22%. And reduction in the pulmonary air leaks around 23%. So all these trials, what I have shown, actually they are not uniform. Some trial was with the synchronized machine, some was synchronized machine. They have told that synchronization used to deliver NIPPV may be important. However, data are insufficient to support strong conclusions. Although in our unit we are using for last 5 years, we are using non-synchronous NIPPV, and our treatment failure rate is around 10%, around 10%. That means 90% babies can be managed your NIPPV in non-synchronous only if you do not have a synchronous machine. Then what are the machines that can be used for NIPPV? NIPV, non-synchronous NIPV can be used any ventilator which can provide nasal CPAP and IMB modes. Ventilator with software for a non-synchronous NIPV, SLF 6000, VN 600, and servo. These are the machines that can be delivered, that can deliver synchronous NIPV. But one important point to remember, if you use non-synchronous NIPV machine, you can use the non-synchronous. If you do not have a software, it will give a lot of alarm. It's like Babylog 8000 plus. In Babylog 8000 plus, there is IMB mode. If you can use IMB mode with a flow of 8 to 10 liters, only thing that might happen, so there will be a lot of noise that we have to tolerate. But if we have a software for non-synchronous NIPV, that noise will not be there. So these are the machines available in the market which can be used. If you carefully see this slide, you will find only FDA approved a machine is Infenstar 950 and Servo I. Rest of the machines are not actually approved by synchronous machine are not approved by the US FDA. That is the reason the minimum trial has been done with synchronous NIPV machine, because in US hardly any machine is approved for nasal synchronous NIMB. So in our unit, these are the machine we use. The first machine you see, this is Babylog 8000 plus. Second machine, what we have seen, this is the Servo N. Third machine, what we have seen, that is the VN series, VN 600. The fourth machine, what we have seen, this is the SLS 6000, and this is the Hamilton. So these are the interface that you can use. What we use in our unit, if the baby is small, then we use Dagger interface, and also we can use RAM cannula. But whenever you are using any interface, whether you use for CPAP or nasal intermittent positive pressure ventilation, you should be always careful so that the nasal trauma is prevented. Because one of the what we do sometimes, if you find that I am using nasal IMP as a primary mode and the baby is improving, then immediately I'll switch over to nasal CPAP. And whatever machine I am having, in all those machines, in the same machine, I have got a facility for nasal CPAP, nasal IMB, synchronous IMB, non-synchronous IMB, nasal high frequency in some machine also, NIMB NAVA, and also IMB mode. That means you don't have to change the ventilator once you connect it to the baby. So now this is a baby which is connected with the NIV, synchronous NIV. You see, you can clearly see from this slide. So this triangle is showing these are synchronous breath. And you look at the baby. Baby is comfortable with this synchronous machine. This baby is connected with the your NIV synchronous with the Hamilton machine, Hamilton C1. So how do you know this baby is synchronizing? All this, the triangle what is coming, that means these are all synchronized breath. So, and you can see the baby is comfortable in the NIMB synchronized. But I tell you, even the baby is a non-synchronous NIMB, you can use it. So only thing is that if it is non-synchronous, and these machines, another important thing is to remember, this machine has got an automatic flow adjustment. That means what I told you earlier, in a non-synchronous NIMB, what happens, because of the leak, you may not get the appropriate PIP what you have delivered. Suppose here it is showing 19. So if you said 19, suppose 19 pressure is not actually delivered, that means there is a lot of leak. So in that case, in a non-synchronous NIPV where this flow leak compensation is not there, you have to increase you have to fix the interface carefully and also increase the flow. So we say that we cannot increase more than 10 liters. So by increasing or adjusting the flow, you can set your PIP. So how do you know that your leak is not there? You can see what is the set pressure and what is the delivered pressure. Here the set pressure is around 19 and the delivered pressure is 19. That means leak is compensated because this baby is also connected to the RAM cannula. So that is the way you can see. So this is the next baby you see. This baby is connected to is a NIMB, and this is a little bit bigger baby. And you see the white that marker. This white marker shows that these babies are synchronized, but this is a pressure synchronization. Pressure synchronization is problematic because baby has to generate a good inspiratory effort. This baby, I was fortunate to capture this. Actually, this is a bigger infant. This is a 2-month-old baby. This is readmitted. So this baby is a bigger infant. That means its inspiratory flow is very high. Perhaps this is the reason there is a decrease in the flow and every breath is recognized by the machine. You see, every breath is recognition, baby is also comfortable. That means synchronization may be done by the flow. And the first picture, what I have shown you, that is the flow synchronization. This is flow synchronization. Another and second picture, this is the pressure synchronization. Another important point to note, when always try to keep this end of the flow sensor little bit down, because if there is condensation in the flow sensor, that may cause auto triggering. So that is another practical point to remember. I think this baby is comfortable in this mode. And that this flow trigger can be actually, some of the machine they say that flow trigger can be actually increased by decreasing the resistance. Dr. Rajesh was telling that if we use that RAM cannula, the resistance may be higher. But some studies have shown that RAM cannula has got the lowest resistance as compared to nasal prong or nasal mask. Another important thing is that I have told you that there will be a lot of leak, and also some amount of air will go inside the stomach. So this is very important that you have to evacuate the stomach time to time, and you feed the baby and keep the feeding tube little bit higher, so that whatever air goes into the stomach, that can go out. So these are the things. If you want to set PIP, you say chest rise, that's SpO2. PP set by seeing the retraction, chest X-ray, lung expansion. Respiratory rate by the respiratory rate, FiO2, by seeing the saturation and flow, may be fixed or variable, as we have already discussed. So if you use as a primary mode, you can set the PIP 16 to TNT, P 4 to 6, TI 0.45, frequency around 40, flow around 8 to 10, and FiO2 around 30. If you use at a primary mode, maximum support you can go up to 25. Minimum maybe 12, maximum 25. PIP 6 to 8. This is a map. TI maximum you can go 0.5, frequency 45, flow 10 to 12 liters. But if you increase the flow, there is a risk of abdominal distension, sometimes even perforation also, and FiO2 maximum 60%. As a secondary mode, whatever it was in the conventional ventilation, you can give 2 to 4 centimeter, because there will be a lot of leaks, some amount of dampening of the pressure will be there. So PIP you can give 4 to 6, TI 0.45, frequency 40, and flow 8 to 10. Similarly, recurrent apnea, as it was told earlier, yesterday also, you keep PIP on the lower side and respiratory rate around 20, because here baby is having apnea, so you cannot keep the rate of 40. This is a weaning. You reduce the PIP 1 to 3 centimeter, so that it reaches around 12 to 14. And secondly, lower the rate by 2 to 4 breaths every 2 to 4 minutes, so that 20 breaths per minute. So, and when the frequency is less than 20, PIP 12 to 14, P 4 to 5 centimeter less, or FiO2 less than 30, you can wean. These are the things. This is called when the NIPPV failure, experiencing more than 4 apnea, frequent desaturation, and moderate to severe retraction. What is BiPAP? There is a difference between BiPAP. BiPAP, the respiratory rate will be low, and the TI is very high. It is same just like NIPPV, but here the respiratory rate of TI will be high. So what are the differences? Here the PIP and PWP, the difference will be more than 5 centimeter, but in BiPAP it will be 3 to 4 centimeters. This is a bi-level CPAP. So one, there will be higher MAP, another will be higher CPAP, and in the second will be lower CPAP. And the inspiratory time is short in case of NIPPV as 3.3 to 0.5, and in the BiPAP with 0.5 to 1 second. In COVID time, we have heard a lot of BiPAP, but in neonatology, BiPAP is not used very much, because we cannot use that much of respiratory effort rate, because it is around 20, not more than 20. But some evidence says that BiPAP may be better than CPAP, but you need a machine or flow-driven BiPAP, so it is not used much. So the synchronization can be done by pressure, can be done by Glasgow capsule or flow. Third is the NAVA. NAVA means neurally adjusted ventilator assist. What it is done? Here there is a catheter that is pushed into the esophagus, lower 1/3 of the esophagus. This detects the electrical activity of the diaphragm. Once it detects the electrical activity of the diaphragm, that means it is synchronizing the breath. So, but if the patient does not have any respiratory effort, that it will not be able to detect the breath. So what happens? You put a catheter in the lower 1/3 of the stomach and 1/3 of the esophagus. So this feeding tube has got a catheter embedded in the lower 1/3, and also feeding. That is a facility for feeding. So what this catheter will do? This catheter will detect the electrical activity of the diaphragm. Just like the flow trigger, here also we can use the ED signal. ED means electrical activity of diaphragm, and the threshold usually kept 0.5 microvolt. So once the baby is taking breath, it will detect the maximum inspiration, that is called ED maximum, and also minimum ED minimum, that is the expiration. That means it will detect the maximum peak and also minimum peak. And what it will do, you set a NAVA level. NAVA is an arbitrary number, and this ED signal maximum minus ED minimum into NAVA is around PIP, that PIP that will be delivered. That means PIP will be delivered by the patient based on the maximum ED, minimum ED. So that will detect the maximum minus minimum ED. Suppose maximum ED is 20 and minimum ED is 5. That means 20 minus 5, 15. And NAVA level you have kept 1. That 20 into 1 to 1 plus P5. That means 25 centimeter pressure will be delivered. So that is what is shown here. This is the NAVA catheter. There is a catheter embedded here, and this is a feeding tube. And this will be connected to the ventilator, as we have seen. These are the parameters we have set. We have to set the oxygen concentration, PIP, PWP, NAVA level, this is arbitrary number, and also ED trigger. And you need a backup rate. In also NIPPV, we need a backup rate. Suppose baby is not triggering the breath, so there is no diaphragmatic contraction. In that case, whatever backup rate you have set, that will be delivered by the machine. So these are the different settings that we have shown. The NAVA level usually kept 2 centimeter per microvolt. ED trigger 0.5 as we have to pressure alarm 30 to 50, apnea time 2 seconds, and backup rate like the normal NIPPV. So in the case of non-synchronization, the backup rate will come and do is deliver. These are the weaning. Suppose when the patient is in NAVA, you have to see whether the baby is on NAVA or in the backup. So in the weaning, you have to see if the ED peak is less than 0.5 microvolt, that means mostly in the NAVA. Then you have to decrease the NAVA level 0.5 centimeter, water pressure by microvolt until a level of 1 centimeter is reached. And if the intubated, extubate to NIV NAVA. And if on NIV NAVA, change to CPAP or SFNC. If the ED peak is less than 5 microvolt, the mostly in the backup ventilation, then you have to reduce the backup rate. So if the ED volt minimum is less than 2 microvolt, then there will be low FIO2, you can win the 1 centimeter. Just remember, my idea of telling is that this base synchronization can be made by NAVA because it is directly actually detecting the electrical activity of diaphragm. And it will electrical activity of diaphragm during inspiration as well as inspiration. And it will deduct these two and multiply with the NAVA level, and you just add the PIP, that will be PIP. That means PIP will be delivered by the machine based on the ED signal. So evidence, there is not much evidence on NAVA. So the last thing what I am going to discuss is that suppose I am connecting a baby with Nasal synchronous NIMB or non-synchronous NIMB, and baby is failing in synchronous NIMB. Should I go to IMB? Definitely not. What we should go? We can go to non-invasive nasal high frequency ventilation. Here what happens? Non-invasive approach in which high frequency pressure changes are added via any device to provide high frequency modulation to flow. I think if you can remember in the past presentation, bubble CPAP, there may be some oscillation, just like your nasal high frequency. This modulation can be oscillatory, interrupted, or pulsatile in design, and sub-physiological tidal volume has supra-physiological rate. And these are the nasal high frequency. So what are the advantages of over CPAP? Here you are getting some oscillation and you are increasing the MAP to a great extent. That means you are getting the advantage of CPAP, or also you are getting some oscillation, which in CPAP you may not get. In bubble CPAP you may get some oscillation, but in nasal high frequency oscillation you will get more oscillation. And the carbon dioxide elimination is better and work at a higher mean area pressure. As I told you earlier, in the NIPPV or synchronous NIPPV, you cannot go mean area pressure around 10 or 12, maximum 8 or 10. But here you can go more than that. So what are the advantages over the NIPPV? High frequency oscillation eliminates the need for synchronization, better patient interaction, less Gaussian distension and feed intolerance, more effective carbon dioxide elimination. Like this, we have seen, this is the oscillation. This baby is connected with the nasal high frequency oscillation. This oscillation going on. So what are the settings we have to set? You have to set directly MAP and FiO2, and for ventilation we use amplitude and frequency. Normally we do not touch the frequency, we actually set the amplitude. Frequency is kept around 8 to 10. So this is the patient. Now baby is connected. This baby is connected with the nasal high frequency oscillation ventilation. You can see the oscillation. Now you can tell me, you can ask me up to what this oscillation should be. You can see that there is some oscillation in the chest as well as the neck also. And you can see the tube also is oscillating. So this is non-invasive nasal high frequency oscillation ventilation. And this baby is a bigger baby. And what we have seen, if you use non-invasive nasal high frequency oscillation, baby tolerates very high. Because in non-invasive, non-synchronous NIPPV, the tolerance will be low because there will be a lot of breath will be synchrony. But here you can negate the effects of synchrony because you are ventilating the baby with a supraphysiological rate. Like if you keep 10 hertz, that means in this baby that frequency is kept 10. That means 600 breaths baby is getting. I ratio is 1:1. Peak level is kept around 28, the amplitude. And the mean area pressure kept 10 and FIOD is 35%. With this baby is baby comfortable. This baby we could extrovert. Actually today morning this baby has been shifted from nasal high frequency to nasal CPAP. So in our unit, what is our actually plan? Any baby comes, whether it's a primary mode or secondary mode, we start with the nasal IMB. Suppose you do not have the ventilator, you start with the nasal CPAP. Suppose if you nasal CPAP baby fails, then you can go to nasal IMB. You may be having nasal non-synchronous machine or synchronous machine. It is not a problem. Whatever machine you are having, connect the machine with the with NIMB. Suppose in NIMB also baby fails, if you have got the ventilator which has got the facility for nasal high frequency, you can connect the baby. So your ultimate requirement of mechanical ventilation will be reduced to a great extent. So these are the setting. You set MIP around 3 to 5 centimeter above the map on NIPPV, amplitude around 15 to 35, frequency 8 to 12 hertz, I ratio around 1:1, inspiration time 50% to 33% of the cycle time. In FiO2 is less than 0.3, MEP is kept around 6 centimeter into NIP. So there are a lot of evidence. It is shown that non-invasive high frequency oscillation ventilation as a preterm infant. It is so there is a meta-analysis with NIPV. It is shown that NIPV is not nasal high frequency oscillation ventilation is better than NIPV. The last non-invasive oscillation ventilation versus nasal continuous positive airway pressure versus as post-extrusion support preterm infant in China. This is one of the biggest trial. It has been shown that duration of IMB was slightly but significantly lower with nasal high frequency oscillation ventilation than with either nasal FIPAP or nasal IPV. However, there are no significant difference in the duration of IMB between nasal CPAP and nasal IMB. So this is a trial we did in our unit, nasal IPPV versus nasal high frequency oscillation ventilation. Our sample size was very small, around 80 babies. And here we have found that our failure rate was around 10%. There was no significant difference between the failure rate. Extubation failure, there is no difference. But what I have seen that as a rescue mode in the later part after the trial was over, the nasal high frequency can actually prevent some babies from mechanical ventilation. So what we have learned, CPAP is still the standard of care, but nasal IPPV is one of the most effective model NIV for respiratory support to preterm infant. Nasal ventilation is a bridge between CPAP and invasive ventilation. Nasal IPPV is better than CPAP as both as a primary and a secondary mode. And one should try NIPPV as a primary mode if there is an availability of ventilator, which may not be possible in many centers. Nasal high frequency oscillation may be another bridge between NIPPV and IMB. Synchronization issue in NIPPV, however, evidence suggests there is not much difference in non-synchronous and NIPPV and synchronous NIPPV. Effective synchronization may be done possible with NIV NAVA or with synchronous NIPPV flow sensor, but clinicians should make every effort to avoid mechanical ventilation. So our target is to avoid the ET tube in the unit. If we can avoid ET tube in the unit, your 90% job is done. As we have discussed and we have seen clearly, 90% babies can be managed with any kind of nasal ventilation. Only 5 to 10% babies may be ventilated. Even after short ventilation, they can be switched over to nasal IM. So this is the quote from Professor Elanjo. What he says, mechanical ventilation in the newborn is a necessary evil. We do it because we must, not because it is good. Thank you very much. Thank you for your patient hearing. If you have got any query, I'll be happy to answer.
Good presentation, Bijan.
Yes, thank you.